Today I am going to discuss about a landmark trial called HOPE-3 trial, which was reported this year in Lancet. This is a trial which might change our practice regarding statins. This trial is called as Heart Outcome Prevention or HOPE-3 trial. This trial was regarding cholesterol lowering in intermediate risk persons without cardiovascular disease. The background of this trial is that the role of lowering LDL is not very clear in patients who do not have high cholesterol, who do not have inflammation, who do not have hypertension, and who do not have diabetes. These are called so-called intermediate risk patients. As you know, statins are extremely useful drugs for secondary prevention. They are also very useful for high risk primary prevention. They are not good for low risk primary prevention, but intermediate risk, it's not very clear. There are a large number of patients who have this risk, and therefore this study was planned to see whether statin therapy, even without monitoring in a small dose, can help these patients. The objective of HOPE-3 trial was to determine the effect of rosuvastatin 10 mg in patients of various ethnic groups in various countries who were at intermediate risk. The study design was 2 × 2 factorial. It involved about 12,000 patients from 21 countries including India. Rosuvastatin or placebo was given for 5.6 years and they were followed for various parameters. The endpoint of the study were two targets. The first target was total cardiovascular mortality, non-fatal myocardial infarction and non-fatal stroke. The second co-primary target was, in addition to these, there was a need for revascularization, there was sudden death also was included. These were the two targets which were really seen after 5.6 years. The inclusion criteria of this study included males above the age of 55 years or females above the age of 65 years who had in addition one of the following 5 features. Firstly, they had increased waist-hip ratio or central obesity. Secondly, they had history of low HDL. Thirdly, they were current or past smokers or taking tobacco and dysglycemia, or premature history of family history of heart disease or mild renal dysfunction. The results of this study, which were taken at the end of 5.6 years, showed that there was an excellent adherence to statins. It was 83% at the end of 1 year, it was 80% at the end of 3 years, and 75% at the end of 5.6 years. And in the placebo also similar compliance was there. So it was an excellent compliance, and both placebo as well as statins were well tolerated and well taken. The cholesterol was significantly reduced in patients who were taking rosuvastatin. Actually, the LDL decreased by 26.3% and ApoB also decreased by about 25% at the end of 5.6 years as compared to controls. The first co-primary endpoint was significantly reduced by 24%. That is, there was a reduction in death due to myocardial infarction, reduction in non-fatal myocardial infarction, and reduction in non-fatal stroke. The second co-primary target, that is, if we included with these 3 features, revascularization, history of heart failure, or resuscitation from cardiac arrest, was also significantly reduced by 30%. If we take individual factors like stroke, that was reduced by 30%, and myocardial infarction was reduced by 35% at the end of 5.6 years in the group which was taking rosuvastatin as compared to controls. Even the need for coronary revascularization, that is angioplasty or bypass, was reduced 27% by rosuvastatin in this group which was having no heart disease at the beginning. Thus, to conclude, HOPE-3 trials gives us a very good information. That is, if the patients are at intermediate risk, then one can give rosuvastatin and decrease the risk for heart disease significantly. It also is a very simple method of treating these patients without any monitoring. So if you have a patient who is at intermediate risk, that is a male above the age of 55 years or a female above the age of 65 years who has either central obesity or low HDL or is a smoker or has premature history of heart disease or has mild renal dysfunction, you should give rosuvastatin. There is no need of monitoring any parameters, and this would be extremely useful for primary prevention of coronary artery disease.